Welcome. Today, we're going to tackle one of the most interesting areas in surgical coding, the skull base. Now, I know it looks super complex, and honestly, it is. But once you get the hang of the CPT framework, you'll be able to break down any skull base op report with total precision. So let's get you ready to code these with confidence. Okay, just think about this for a second. You've got a neurosurgeon, an ENT, maybe a plastic surgeon too, all of them working on the same patient at the exact same time to take care of one lesion. I mean, how in the world do you code for that? This isn't just a random question. It's the absolute core challenge of coding for skull base surgery. And that scenario right there, that defines our first big challenge. Skull base surgery isn't just another procedure. It is the ultimate team effort. And because of that, it needs its own special coding playbook. So what makes it so different? Well, first off, you have that whole team of specialists all working together in one single high-stakes session. They can't just stop and pick it up again tomorrow. These procedures are not staged. And the risk of a really serious infection like osteomyelitis or meningitis is just incredibly high. So when they go in, they have to achieve a definitive final closure before they leave that OR. It's a one-shot deal. So how did CPT solve this massive coding puzzle? Well, they came up with this really elegant framework that's built on one surprisingly simple idea. The solution is the number 3. Seriously, that's it. Everything comes down to this number. To code any skull-base surgery, you just have to break it down into 3 distinct logical parts. And here they are, your 3 core components. Think of it like a special ops mission, right? The approach is all about creating the path to get to the target. The definitive procedure, well, that's the mission itself, dealing with the lesion. And the repair, that's the extraction and cleanup, making sure everything is totally secure on the way out. Approach, definitive, repair. Simple as that. So now that we have the blueprint, let's really break down what each of these components means. Mastering these definitions is what's going to let you confidently pull the right codes straight from any operative report. First up is the approach. This is purely about getting access. The surgeon, or sometimes a whole team of surgeons, is just creating a pathway to get to that lesion. The codes for this part are categorized by which part of the cranial fossa, which is just the floor of the skull, they're entering. Anterior, middle, or posterior. The op report is your map. Next, we've got the definitive procedure. This is the main event. It's the whole reason the team is in there in the first place. This is the code that describes what was actually done to the lesion. And hey, pay close attention to this part. This code includes the simple primary closure of the immediate layers, like the dura. That's considered a built-in part of the main procedure, not some separate repair job. But what if the closure isn't so simple? That's where our third component comes into play. This isn't for a few simple stitches. No way. Think of this as a separate, major construction project. When the defect left behind requires really extensive work, like dural grafts or a cranioplasty to replace bone or complex tissue flaps, that's when you report a separate repair code. Okay, so we have our 3 puzzle pieces: approach, definitive, and repair. Now, how do we put them all together on a claim? Well, it all comes down to answering one simple question. Who did what? You're going to see 2 main scenarios. First, if you have multiple surgeons, it's actually pretty simple. Each surgeon bills only for the part they personally performed. So the neurosurgeon reports the definitive procedure, and the ENT reports the approach. See? Easy. But if one single surgeon performs more than one component, they report a code for each part they did, and they'll append modifier 51 to the secondary procedures. That modifier 51 basically tells the insurance company, hey, yep, these are separate procedures, but they were all done by me in the same session. It's your signal for a single surgeon wearing multiple hats. Now, before we wrap this up, there is one absolutely critical add-on code in this series that you have to know about, and it involves the carotid artery. So, if the surgical team has to transect or ligate the carotid artery while they're doing one of those main definitive procedures, you report the add-on code 61611. This code never gets used by itself. It's always added on to capture that extra complex work. But here is the most important rule, and I really want you to burn this into your memory. You can only report this code once per operative session. It doesn't matter if multiple branches were involved, doesn't matter what the circumstances were, the guideline is absolute. 1 session, 1 code, 61611. This is a super common area for mistakes, so you've got to be vigilant. All right, we've covered a ton of ground. Let's pull this all together and assemble our final coder's blueprint. This is your go-to guide for any skull-based surgery report that lands on your desk. So here it is, your blueprint. First, always remember, it's a team sport. Next, always break that op report down into those 3 parts: approach, definitive, and repair. Then you figure out who did what, because that's going to determine how you report everything. Keep your eyes peeled for those special add-on codes, and please, never forget, Modifier 51 is your absolute key when one surgeon does more than one part. So I'm going to leave you with this question. After walking through this whole framework, what is the very first thing you're going to look for the next time you open a skull-based operative report? Because now you have the blueprint to deconstruct it. You know exactly what you're looking for.